Hello again, this is Cameron Popal and I'm back again with another emergency scenario. This is not very common, but it's something for you to mention. This is extra stations, so I probably would do both these extra stations together. So one of them is a penile fracture, the other one is paraphimosis. So penile fracture, what is a penile fracture? So rupture in tunica albuginea of the penis, usually at the ventrolateral aspect during sexual intercourse. So the key points in history include an audible noise such as a snap and a pop, immediate detumescence, penile bruising in an aubergine pattern, and mechanism. And the other thing that I would ask would be mechanism of injury and what time it happened, any subsequent erection, any hematuria, thinking about urethral injury, any baseline erectile function pre-injury, and fitness for surgery and performance status. On examination, you're looking for aubergine sign, palpable defect in the ventrolateral aspect, blooded meatus and retention, which may suggest urethral injury. Investigations wise, this is usually a clinical diagnosis, but adjuvant imaging can be used, but we will speak to the consultant or an andrological center where they may consider or ask us to do an ultrasound or MRI of the penis. Urine dip needs to be done to look for any microscopic hematuria, and on-table ureterogram is also suggested if urethral injury is suspected. How would you manage a penile fracture? So there's no place for conservative management of this because this can cause erectile dysfunction, curvature, and fibrosis. Surgical management should happen within 12 to 24 hours. The way you do it is degloving or direct incision on the defect if it is palpable, hematoma evacuation, and repair of the tunica with 2 OPDS, and if the urethra is damaged, then 4 OPDS over catheter for the urethra. And on-table ureterogram needs to be done if there's urethral injury. So this is your penile fracture. The next station is paraphimosis. This is also an extra station, can be asked. I think it was asked in a couple of years ago. Quite interesting. And what is paraphimosis? It is inability to pull forward a retracted foreskin over the glands. What are the risk factors? Number 1, phimosis, either pathological or physiological, recent instrumentation or catheterization, poor hygiene, carer dependent, which may raise a safeguarding issue, and trauma. So all of these are risk factors. So when you take a history, if you know the risk factors, you can, and you're structured enough, you can obviously figure it out and make sure you mention these risk factors within it. Pathophysiology. The pathophysiology of paraphimosis is painful vascular enlargement of glands due to phimotic prepuce causing a constricting band proximal to the glands. So, it's basically the definition, but, a better way of saying the pathophysiology. Complications, if untreated, it can lead to ischemic necrosis of the glands and prepuce, and potential for Fournier's gangrene as well. Moving on. How would you manage this? So first of all, give analgesia oral or consider a penile block, and then you should use Madel reduction. So squeeze the paraphimotic tissue, which is quite edematous usually, and gradually increase the pressure and to squeeze the edema out for about 5 to 10 minutes, and then try to move the constricting prepuce ring beyond the widest part of the glands. Usually you use a 2-finger technique. Other methods to reduce edema are ice packs. Some people use sugar solution. Not always recommended by urologists, but then there's another method which they sometimes want to hear, is the Dundee method. So multiple pricks and with an orange needle, and then squeezing the edema out, and then using Madel reduction method. If this is unsuccessful, the patient needs this needs to be tried on a general anesthetic, and dorsal slit may be required. And you do not do a circumcision immediately because everything is very edematous, but you plan for a circumcision later on if the patient is not happy with the cosmetic appearance of the dorsal slit. Okay, so that were the 2 extra stations. I would be answering, this is not the extra questions that I was talking about, they were extra emergency stations that I had written down, but there will be other, I will do a video of extra questions towards the end, which are basically related to the interview. So keep an eye on that. That will be towards the end. There will be extra questions, some additional information, and hopefully you're learning from all of this. All the best, and hope you all get a national training number.